Thank you very much. Thank you very much, Dr. Eleanor Fish, for the introduction. There's only 1 hour difference between Toronto and Winnipeg, so I apologize for being delayed with logging in. Anyway, I hope everything is well in Toronto as it is in Winnipeg. So today, this morning, I'll talk about the most recent highlights of our group's research on infectious diseases, including schistosomiasis and HIV. And I'm talking today on behalf of our colleagues and collaborators from the International AIDS Vaccine Initiative, Uganda Virus Research Institute, as well as the University of Toronto. And I myself, I'm a PhD student in the Department of Immunology in Toronto. So um, I'll begin my presentation with a short introduction into schistosomiasis. Schistosomiasis is a neglected tropical disease, also known as bilharzia or snail fever in some parts of the world. And we'll just call it schisto for short because many people have trouble pronouncing this word. So schisto highlight component that we are focusing on. So this disease affects more than 230 million people worldwide, and it's still neglected, like I just mentioned. So there are two major predominant forms of schistosomiasis. One is intestinal schistosomiasis, and one is genitourinary schistosomiasis. So this picture here shows a boy with very typical symptoms of intestinal schistosomiasis, which is a swollen belly. And essentially, I won't go into details, pathology and stuff right now, but it's caused by this parasite called Schistosoma mansoni. And this is the predominant form of schisto species in Uganda, and that's the one species I'm going to focus on in this presentation. Uh, these are the parasite worms that all schistos that cause schistosomiasis. Again, they're the main parasite we're focusing on today is Schistosoma mansoni. And people get schistosomiasis in contact with contaminated water. So schistosomiasis is also, it's important to mention, it's a disease of poverty and unsanitary conditions. So the absence of proper sanitation, lakes and rivers get schistosoma eggs and they hatch into larvae and infected with this larvae when bathing, fishing, and or for any other uh, means of water consumption. So not only schisto affects so many people in the world, uh, and it actually is a chronic disease. A lot of the time, it does not present any symptoms until later in life or usually infected with schistosomiasis. So there are some pathological sequelae that can follow an untreated infection. And not only that it has this pathological sequelae, but it also overlaps with HIV in our. So these are so so these are the maps of Africa. Um, the one above you, the map you see above is schisto. The one below is for the distribution of HIV. As you can tell from just looking at this, as you can tell from looking at these maps, schisto and HIV overlap geographically, and there's some epidemiological evidence that schistosomiasis can increase HIV susceptibility. There's some recent epidemiological studies that showed that women with schistomansoni infection are 6 times more likely to have HIV, or about 3 times, and they have about 3 times higher risk of HIV infection compared to women without schistosoma. This relationship is still under study, and more studies, in fact, are needed to better understand the immunological relationship, how schisto increasing HIV susceptibility in women. So the objective of our study was to assess the relationship between schisto infection and behavioral HIV risk factors in adult women. And we wanted to do this as part of a larger clinical study where we wish to assess the effects, immunological effects of schistosomiasis and HIV susceptibility. And as you know, if you are doing a clinical study, you actually want to take into account every possible confounder that there is. So I'm being told that my microphone is not loud enough. I wonder if I can change it here. Or so the study we conducted was done in the region of Uganda, which is close to the shores of Lake Victoria, in a town called Entebbe. So here you see the location of the study site, and this geographic location is primarily home to semi-urban, rural, and fishing communities, with some communities having very high rates of HIV, reaching about 30%, with the incidence of HIV about 5%. And it also is this region also has high prevalence of schistosomiasis, about 50% and more, mostly predominantly schistomansoni infection. So for the study, we recruited adult women who consented for the study from a few clinics in Entebbe town. So women were eligible for the study if they were negative for pregnancy, HIV, and malaria. And we conducted a series of tests. First of all, to screen for schistosomiasis, we used a rapid diagnostic test on urine samples, which is based on this circulating cathode testing. We also performed some retrospective serology and PCR for schistomansoni and schistohematobin actually as well. We also screened for 3 different sexually transmitted infections. We collected swabs for bacterial vaginosis testing, as well as for testing for prostate-specific antigen, which is a proxy for recent sexual activity. We also conducted complete blood counts, HSV2 serology, and assessed socio-economic and behavioral characteristics of our participants using questionnaires. Okay, too loud now. All right, is this good enough? Okay, so we are on the first set of results for this. I'll go through this table rather maybe slowly at the beginning to explain what every column is. So the median age of the participants in our cohort was 27.5 years. We had 58 adult women in total enrolled into the study. 33 of them were schistopositive and 25 were schistonegative. And as you can see from the p-values here, women with schistosomiasis were significantly younger than women without, which is in agreement with literature. So just to give you an idea about this statistic here, this is OR, or odds ratio. So anytime you see a value above 1, this would tell you that the association we're seeing with schisto is positive. And if the value is below 1, we are looking at an inverse correlation. So both of the values here are below 1, as you can tell. And for women, for the marital status of women, we also saw a significant difference between schistopositive and schistonegative women, in that schistopositive women were significantly less likely to be married, which is also expected since they were younger. Next set of results here, actually right here, before we jump on to the next slide. So, okay. So the next set of results shows us the percentage of women using hormonal contraceptives, and there are three subtypes that we collected information on, or had information on. This was a Depo-Provera, another one was Norplant, and another one was oral pill. And the predominant one in the region is really Depo-Provera, and the reason we're looking at it is because it has been associated with increased HIV susceptibility. So the use of hormonal contraceptives was significantly and inversely associated with schistosomiasis. So women with schisto were less likely to use hormonal contraceptives. And again, it's not surprising, since they were younger, they were less likely, and they were less likely to be married. That means they were less likely to be using those hormonal contraceptives. Now, this set of tables, set of results shows you the distribution of three common sexually transmitted infections, and we did not see any association, positive or negative, with schistosomiasis for all three infections. But you will notice that all women with schistosomiasis were, all women that had chlamydia trachomatis infection also had schistosomiasis. So 5 women that were tested for chlamydia were positive for schisto, and that's interesting. However, we are underpowered to further delineate whether this was really a significant association or an artifact in the study. We also looked at sexual activity in the last 3 days using the PSA test. And what we found was a trend. Women with schistosomiasis were less likely to have had recent sexual interaction. We also saw no significant association for self-reported recent sex, condom use, herpes simplex virus, or self-reported genital symptoms, or bacterial vaginosis. So these findings, the findings I just told you about, should be interpreted in the light of limitations. First of all, our study had a small sample size. We only had 58 women, so that makes it difficult to explore some associations in detail, such as those with chlamydia infection. And there might be some possible bias in terms of the actual significance of the associations. We also rely primarily on the CCA test, which is a rapid test for schistosomiasis, known to yield some false positivity when testing for schisto. However, we confirmed this test using PCR, but also serology, and we found some very similar results to testing with CCA alone. So as to finish up and to summarize what I just told you, which probably was very confusing, intestinal schistosomiasis in women from Uganda was associated with differences in participant age, marital status, hormonal contraceptive use, and sexual behavior. We think that the age association, which is very well described in the literature, could be the primary driver of the differences that we see in the study. So all these parameters that we looked at, and some of which turned out to be significant, can modulate HIV risk and alter genital mucosal immunology of women. And that makes it difficult to tease apart the true biological effects of S. mansoni on immunity, and in particular on mucosal immunity. That means that these factors would be confounders for future immunological studies. as an example, we saw a very strong significant association between not having schistosomiasis and using hormonal contraceptives such as Depo-Provera, which have been associated with increased HIV susceptibility. So it's possible, we do have two possible solutions or suggestions for future studies for researchers. One is to have larger cohorts, to recruit larger cohorts of participants if doing cross-sectional comparisons of schistopositive versus schistonegative women, or an alternative is to do a longitudinal assessment of immunological parameters before and after treating the disease. That way, we're looking at the intra-individual changes in immunological parameters, and that would take into account any confounders that might be there between differences between schistonegative and schistopositive women. Just to finish up, I'd like to acknowledge people that participated in the study, so the participants of the study, also the communities of Entebbe town that helped us, and without whose help the study would not have succeeded. I'd also like to thank a number of clinical teams, including those at the clinics in Entebbe, and also at the Ugandan Virus Research Institute. I'd like to also thank my colleagues at the University of Toronto and some of our collaborators, including those in Germany that helped us with PCR diagnostics. Thank you very much. I'll finish on this note.